Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. I want you to picture a tube of toothpaste. Now imagine both ends are open. If you squeeze the middle, the paste has to go somewhere. That is a decent mental model for global drug pricing. Countries like Canada, the United Kingdom, Germany, and France use national purchasing power, price regulation, or formal negotiation to push prices down. They clamp one end of the tube. The United States mostly does not, at least not in any comprehensive way. So when manufacturers look for the market that can absorb the highest prices, the pressure comes out here. That means Americans often pay far more for the same brand name medications than patients in other wealthy countries. Recent RAND analysis found overall U.S. drug prices were about 2.8 times those in other high-income nations, with the gap even larger for brand name drugs. That is not just an abstract national policy problem. It shows up in your employer's renewal notice, in your deductible, in your pharmacy counter conversation, and in the coverage decisions made by public programs that serve Southern Oregon. Last episode, we looked at the larger machine of healthcare spending. Today, we are zooming in on one of the most distorted parts of that machine, prescription drug pricing. I want to explain why it works this way, where the incentives got bent, why GLP-1 drugs bring the issue into sharp focus, and what someone in Southern Oregon can actually do with this information. A major turning point came in 2003 with the Medicare Modernization Act. That law created Medicare Part D, which expanded prescription drug coverage for seniors. In one sense, that was a real benefit. A lot of older adults needed drug coverage and did not have it. But the law also included what became known as the Non-Interference Clause. In plain English, Congress said the federal government could provide the drug benefit, but Medicare itself could not broadly negotiate prices directly with drug manufacturers the way a single national purchaser might. That choice mattered. In most industries, scale gives a buyer leverage. Walmart uses scale. Large employers use scale. Hospital systems use scale. The Department of Defense uses scale. But for years, the largest public healthcare purchaser in the country was largely blocked from using its full size to bargain over drug prices. Meanwhile, Medicare already sets payment rates for hospitals and physicians. So this was not some pure free market zone. We already had price setting on one side of healthcare, but not on the drug side. The Inflation Reduction Act changed part of that story. It gave Medicare limited authority to negotiate a small set of high-cost drugs over time. That is real. But it is still narrow compared with how other wealthy countries approach pharmaceutical purchasing, so the basic shape of the toothpaste tube remains. Now we have to talk about PBMs, or pharmacy benefit managers. PBMs sit between drug manufacturers, insurers, employers, pharmacies, and patients. They build formularies, which are the lists of covered drugs. They negotiate discounts and rebates. They decide which drugs are easy to access, which require prior authorization, and which are effectively discouraged. In theory, a specialist middleman could help lower costs in a complicated market. In practice, this sector became deeply concentrated. The three largest PBMs, CVS Caremark, Express Scripts, and Optum Rx, now handle roughly 4 out of 5 prescription claims in the United States. And because those organizations are tied to some of the largest insurers in the country, the incentives get messy fast. A central problem is the rebate system. A manufacturer sets a high list price. Then it offers a rebate to the PBM in exchange for favorable formulary placement. If the rebate is calculated off a higher list price, the system can reward expensive drugs that kick money back through the chain. So the list price becomes less like a normal price and more like a strategic sticker in an institutional negotiation. That may work fine for a giant employer plan that ultimately captures some of the rebate value. It works much worse for the person with a high deductible. It works much worse for the uninsured patient paying cash. It works much worse for the person whose coinsurance is tied to the list price, not the net price after rebates. This is one reason drug pricing can feel insane at the patient level. The number on the label is not always the real economic number for the institutions in the middle, but it can still be the number that hits the patient hardest. That is not a bug at the margins. It is a predictable result of the design. And I want to be careful here. This is not a cartoon where one side is pure evil and the other side is pure victim. Drug development is expensive. Distribution is complicated. Formularies do serve a management function, but once you build a system that rewards high sticker prices and opaque back-end deals, you should not be surprised when sticker prices keep climbing and patients feel trapped. The pharmaceutical industry's real argument. To be fair, the pharmaceutical industry does have a serious argument, and it should be acknowledged honestly. The United States plays an outsized role in funding and rewarding pharmaceutical innovation. A great deal of early science comes through American research institutions, federal grants, venture capital, and a market willing to pay more for new therapies. If every country drove prices down aggressively, some drug makers would argue that fewer therapies would get developed. There is some truth there. Innovation matters. New drugs can save lives, reduce disability, and sometimes prevent much larger downstream costs. But a serious point can still be overstated. The real question is not whether innovation deserves reward. Of course it does. The real question is whether Americans should be carrying such an extreme share of the bill, and whether the prices being rewarded always reflect genuine therapeutic breakthroughs rather than marginal variations, patent extensions, or market power. Those are different questions, and once you separate them, it becomes easier to say two things at once. One, yes, we want a system that continues producing valuable new therapies. Two, no, that does not automatically justify every pricing outcome we currently tolerate. Now let us bring this home. Southern Oregon is not insulated from national drug pricing. We feel it through public programs, employer coverage, and household budgets. When premiums rise for a business in Medford or Grants Pass, specialty drug spending is often part of that story. When a family in Ashland hits a deductible early in the year, the list price of a medication suddenly matters a lot. When Medicaid programs limit access to expensive drugs, local patients feel that first, not policy analysts in Washington. And our region has some specific vulnerabilities. Southern Oregon carries a meaningful chronic disease burden. Obesity, diabetes, cardiovascular risk, and access barriers are not abstract topics here. They affect real households across Jackson, Josephine, Curry, and southern Douglas counties. AllCare, one of the major regional organizations involved in Oregon health plan coverage, serves tens of thousands of Medicaid members in this part of the state. When drug costs explode, public and quasi-public systems like that have to make hard coverage choices. That means drug pricing does not just shape convenience, it shapes access. There is also a practical local spillover that matters. When a regional employer in Medford or Grants Pass absorbs another premium jump, that pressure does not stay in the benefits office. It can show up as slower wage growth, harder hiring, leaner staffing, or more cost shifting onto employees. When a public plan has to guard its formulary because specialty drug spending is exploding. That pressure does not stay inside the plan. It shows up as tighter rules at the point of care. So even people who are not taking expensive medications are still living inside the economic weather created by expensive medications. It is worth asking a simple question. If other wealthy countries get access to many of the same drugs, why are they able to pay less? Usually some combination of four things. First, they negotiate as a much larger, unified buyer. Second, they are often more willing to say no, or at least not yet, when a manufacturer sets a price that does not line up with the clinical value. Third, they tend to use health technology assessment more explicitly. In other words, they ask whether a drug is meaningfully better than existing options, and if so, how much that improvement is worth. Fourth, their systems are usually less fragmented. There are fewer layers, fewer disconnected payers, and fewer opportunities for the kind of rebate games that thrive in complexity. Now, those systems have trade-offs too. Some countries get slower access to new drugs. Some are more restrictive about who qualifies. I do not want to pretend there is a frictionless utopia somewhere else. But there is a difference between accepting trade-offs and pretending the American result is inevitable. It is not inevitable. It is designed. If you want one class of drugs that exposes the problem clearly, it is the GLP-1 medications. You have probably heard the brand names: Ozempic, Wegovy, Mounjaro, Zepbound. These are not hype-free miracle drugs. They have side effects, access issues, and appropriate use questions. But they are also not fake. The evidence is real. These drugs can produce meaningful weight loss and improve metabolic markers in many patients. Some also reduce cardiovascular risk in specific populations. So this is exactly the kind of category where a healthcare system should want to think clearly. The problem is cost. In the United States, list prices for brand name GLP-1 drugs have often landed around $1,000 a month or more, which puts annual cost in the rough range of $12,000 to $16,000 before coverage, rebates, or discounts. At those prices, a drug can be clinically promising and still be fiscally destabilizing. That is why many insurers and Medicaid programs do not simply say yes across the board. And this is where people get confused. They hear, "This drug works. Why won't the system cover it for everyone who qualifies?" The answer is not usually because it does not work. Often the answer is because the budget impact at U.S. prices is enormous. That is a pricing problem colliding with a population health problem. In Southern Oregon, where chronic disease rates are not trivial and incomes are not especially high, that collision matters. The people most likely to benefit may also be the least able to pay cash. So we end up in a warped moral and economic situation. A therapy with legitimate medical value becomes broadly available first to people with strong commercial coverage or personal financial flexibility, while lower income patients face tighter restrictions. Again, that is not mainly a local moral failure. It is what happens when a clinically useful drug enters a distorted national pricing environment. So what should a listener actually do? This is the part I think healthcare media often skips. If you are a listener in Southern Oregon, what can you do with this besides get mad? A few things. If you are a patient, do not stop at, "My insurance denied it." Ask why. Ask whether the issue is prior authorization, formulary status, step therapy, or a diagnosis requirement. Ask whether there is a covered alternative in the same class. Ask whether there is a patient assistance program or manufacturer savings path understanding those are uneven and often exclude public insurance. If you are talking with your clinician about a GLP-1 or another expensive drug, here are reasonable questions. What is the actual goal of this medication for me? What outcome are we trying to change? Weight, A1C, cardiovascular risk, symptoms, or all of the above? What is the expected benefit in someone like me? What are the main side effects and what would make us stop? If insurance says no, what is the next best evidence-based option? What should I compare this against in terms of lifestyle support, older medications, or different treatment strategies? That is decision support, not fear, not blind trust, not rage scrolling. And if the medication is approved, ask one more practical question that matters a lot in real life. What is the long-term plan? Is this likely to be a short-term bridge, a multi-year treatment, or an open-ended therapy? What happens if the drug works well, but then coverage changes? What markers will tell us it is still worth continuing? Those questions are not cynical. They are part of making a durable healthcare decision instead of chasing a temporary authorization. If you are a clinician, when a medication is repeatedly inaccessible, document the pattern. If prior authorization rules are undermining evidence-based care, that is not just a private frustration. It is information that matters for payer policy, Oregon Health Authority feedback, and broader advocacy. Specific patterns travel farther than vague complaints. If you are an employer or benefits decision maker, treat pharmacy spend as a strategic issue, not background noise. Ask your broker or plan administrator, how much of our trend is being driven by specialty drugs? What role are GLP-1s playing? Are we seeing high out-of-pocket exposure for employees? Are rebates being passed through clearly? Do we understand the difference between list price growth and net cost growth? A lot of employers in the Rogue Valley are absorbing healthcare inflation without a very clear view of what is actually driving it. That is understandable, but it is not a good long-term operating strategy. If you care about policy, name the issue accurately. This is not just about greedy companies in the abstract. It is not just about personal responsibility. It is not just about whether one drug is good or bad. It is about incentives. It is about negotiation power. It is about formulary design. It is about who gets exposed to list prices. It is about whether the U.S. wants to keep being the pressure release valve for global drug pricing. That is a clearer political conversation than most of what we usually get, and it leads to a better public question. Not simply, who can we blame this week? But what structure keeps producing these outcomes, and what leverage point would actually change them? And that brings me to the broader takeaway. Drug pricing is not some weird side chamber of healthcare. It is a concentrated example of how the entire system behaves. Opaque incentives, fragmented power, administrative complexity, public anger pointed in the wrong direction, and people at the ground level trying to make rational decisions inside a structure that often is not rational. That is why I keep coming back to systems thinking. If a treatment works but remains inaccessible at scale, that is not only a clinical question, it is a financing and design question. If a patient cannot tell what a drug really costs, that is not only a consumer education problem, it is a market structure problem. If local employers keep absorbing premium increases tied partly to national drug pricing, that is not random bad luck. It is policy showing up on a spreadsheet in Medford. In the next episode, we are going to move from cost to outcomes. If the United States spends more than peer countries and often pays more for the same drugs, Why are our outcomes so often mediocre? Why do Americans still die younger than people in other wealthy nations? And what would Southern Oregon need to build if we actually wanted better health rather than just more spending? That is where this series is headed. For now, here is the main thing I want you to remember. The price of a drug is not just a number, it is the output of a system. And if the output keeps producing unaffordable access, rising premiums, and public confusion, we should stop pretending that is normal. This podcast is for educational purposes only, not medical advice. If this episode helped you think more clearly about why your medications cost what they do, subscribe to the Reimagine Healthcare newsletter at reimagine-healthcare.org. That is where I send deeper breakdowns on healthcare costs, access, and what Southern Oregon can do about them. And if you know a local employer, clinician, policymaker, or patient advocate who keeps running into this issue but does not yet have a good mental model for it, send them this episode. That is probably the fastest way to make this conversation more useful in our region. If you catch an error or want to push back on something, reach out through reimagine-healthcare.org. I would genuinely rather correct the record than sound certain and be wrong. Thanks for listening.